You may notice that I am missing my other half on this official last meetup under the guise of SAMHSA's support for the Mental Health Technology Transfer Centers. As you all may have heard us speak to before, SAMHSA is disbanding with the current structure of the Mental Health Technology Transfer Centers, sadly. And we're waiting to see what the new structure is going to be. And we are figuring some things out on our end, which I'll speak to again at the end of this. So Maria, unfortunately, had a standing conflict with having time off this week with her family. So you get me today. And a lot of me because I'm your guest speaker. So I want to make sure, I don't know why this is discombobulating me, but you all see the slide, the opening slide, title slide, right? Thank you, Madison. Quick. Jen and Madison confirmed. Good. That's all I need to know. Sometimes platforms have an easy way to be able to see what you're viewing. And right now I was like, needed to make sure we were on the same page. All right. I'm going to go ahead and just start with some overview of today. So we're going to do some brief introductions, which that won't take long because it's me, and me. And then get into a special topic of sharing some data and results from the National ACT study, which if you have been with us in the past, you have heard about this study and you've even seen some data come out because we've been sharing it with you at times. So today I'm going to be sharing more with you. You will be the first audience to probably get the biggest glimpse of the overview of the entire study and the findings that we have. It's massive descriptive study and you're still not seeing everything. There's a lot there. So we're excited about getting more and more of these results out. And we'll preserve some time at the end to just do kind of our typical open mic where you can bring up questions that you have and pitch them to me, pitch them to your fellow peers on the call, and then we'll speak to what we're envisioning for the future with our group. So as you can see with housekeeping, y'all are muted. That helps with us kind of managing the group. There will be at times, maybe near the end, where you'll have an opportunity to raise your hand if you want to be able to come off mute and speak to me in the group. Your videos are off too for the purpose of, again, just trying to manage when we have over 100 people in the audience. And this also is being recorded and each of these meetings get posted onto the website. What's going to happen in terms of the website in the future and the content there, again, some of that is still being sorted out. So I would go there in the next month or two while you can to make sure that you have access and able to see a lot of the wonderful content that's been created over the past few years. 5 years of coming together with this group here. And then also there'll be slides posted. You are communicating through the chat. There also is a question box that is where you're really posing a question that you're seeking a response from. So use the chat for more informal comments and speaking, but if you have something you want to catch our attention and to respond to, you want to put that into the Q&A. So this is the Q&A as this slide is showing you. And then again, when you want to come off mute, you'd raise your hand and then we'd be checking on you and seeing if you do want to come on and then have an interaction that way. So for those of you who have not met me before, I'm Lorna Moser. So I've been talking to you for 5 minutes now, and now I'm finally going to introduce myself properly. I am an associate professor in the Department of Psychiatry at UNC's Chapel Hill, and I'm the director of the Institute for Best Practices. So we're a technical assistance training center that does a lot of work in support of our teams here in North Carolina, but also work closely with teams in other states as well. I'm the co-developer, along with my partner, Maria Monroe DeVita, of the tool for measurement of ACT or TMACT, which is a fidelity tool. And both of us do a lot of work with mental health services research and really just providing support and working with state providers, funders, teams across the US. So again, sad to have Maria absent, but we'll represent. This is where I pull up my slides. That's where I went. All right, so hang tight. Let me get these slides up. So all that, we're going to jump into some of the content. So the National ACT study was a study that we were awarded a grant to conduct back in 2019. And like many of us, we did not foresee a worldwide pandemic to rock the boat, disrupt some things. So it's a study that originally was intended to be conducted in 3 years, but with some extensions, it took us about 5. Because we were aiming to collect a whole lot of data, and the sources that we were seeking the data from, many of you all, you had a lot of things on your plate. So it was not as easy to grab all that information. All right, let me get over here. Nope, that's going slow. So the research team as part of this study was myself as the principal investigator, but also was joined by Dr. Maria Monroe DeVita, Dr. Lynette Studer, and Dr. Gary Cuddyback, and then had assistance with Victoria Jeffries as a research assistant, associate researcher, and then also fellow team members for both of our groups have helped out in various ways as well. And Arnold Ventures was the funder of this project. So kudos to them for supporting a massive, unprecedented descriptive study of ACT. So just to get all of us on the same page, you know, ACT is a model that's been around for now 50 years. And it's a really well-studied model. So it earned its kind of being called an evidence-based practice 2 decades ago. It's one of the most researched psychosocial practices for people with serious and persistent mental illness. It's considered the least restrictive care model when you're trying to help people divert and stay out of more restrictive settings. So hospitals, jails, supervised residential settings, homelessness. So it's a really intensive community-based model trying to help people have success with staying out of these places, but also living a life of good quality for them. So you end up having pretty intensive wraparound services. And the team is a tightly coordinated team working together, representing a lot of different disciplines and backgrounds. Services are provided around the clock when you're doing ACT as intended. So it's not a 9 to 4, 8 to 5 type of model. You provide services in the evening if that's what's needed. You provide services on the weekend if that's what's needed. And they operate a crisis line. So they really are kind of like pretty intimately involved in the care of a small group of individuals. So also, as this figure shows you, it really cuts across a lot of different practice areas. There is a piece that's case management, but there's a lot of work that's rehabilitative and really trying to help people find the ways in which they can live life more independently with more wellness and providing therapy, integrated treatment for co-occurring substance use disorders, medication supports. Like there's a lot to doing ACT well and as intended, which to us means to fidelity. So even though this model's been around for 50 years, there is this kind of renewed attention that's been given to ACT as a model. For states that are in a settlement with a state level organization or the federal Department of Justice, ACT is very often called out as a service that they want to see be implemented in the state as part of a broader system of care to help people avoid more restrictive settings. There also just is recognition that as we say roll out 988 in the crisis line, that ACT is an integral part of this broader community mental health and crisis service system as well. The issue is that although we recognize the value of ACT, what we know is that attention to implementing and sustaining ACT with fidelity has not been a huge priority or focus in many areas. And so that's a concern. So our aim was to gather as much information as we could about the current state of ACT for the purpose of helping entities, including providers, funders, policymakers, researchers, trainers, evaluators, to be able to look at teams through the lens of understanding what's happening out there. So filling a knowledge gap so that we can all be making more informed decisions when it comes to supporting ACT. There's a lot to this. It's really complicated to try to understand what are the pieces that really need to be in place to have success. But I think this is an important start, is to literally just exhaustively look at what's happening out there. So here are some select research questions, because this was a big study and we looked at a lot, and I'm sharing some of what we looked at. So the basics of where is ACT implemented across the United States? To what extent are teams' program fidelity being monitored? How is ACT funded and reimbursed? What is the range of fidelity across US teams that have been using the TEAM Act? Which is that fidelity measure that I and Maria are co-authors of, along with Greg T. How do lower and higher fidelity teams perform on core ACT service attributes? So are we seeing differences there? Is higher ACT fidelity associated with some likely desirable outcomes? So again, I'm going to be showing some differences here. We're not going to necessarily show the analyses that we've conducted. I'll speak a little bit to what we found, but do you see differences in terms of use of hospital, number of people in competitive employment? The general attributes of the ACT team, such as their team sizes. What have been the team's experiences around ACT staff recruitment and retention? And to what extent do ACT clients have access to safe, affordable housing or integrated community settings? So we are going to start our tour. Here's a big kind of picture of what our projects entailed. There was 3 major projects as part of this study. One is where we surveyed the states on ACT implementation. We also looked at forensic ACT, FACT, but I'm keeping that separated out for the purpose of this talk as well. We also, so with surveying states, this is where we really are trying to understand for every single US state, Puerto Rico and Washington, DC included. So when I say states, I'm including them as well. What do we see in terms of ACT? We really tried to understand a lot about what was happening in each of your states. Another facet of our study was a project that we surveyed ACT team leadership on their experiences and what's going on with their teams. So we received 306 responses that were part of our analysis, and it reflected people operating in 40 different US states. Another part of the project was where we are benchmarking ACT fidelity and team and client attributes. So we gathered data from 216 teams across 11 states. So here's an overview of methods for surveying the states on ACT implementation. This was a descriptive study. It was intentionally going to seek information from different stakeholders. So we were reaching out to whoever was considered a state-level mental health authority who knew what was happening with ACT in their respective state. Most of the time, we were reaching somebody at the state level. Sometimes we had to go a little more local. Sometimes we were reaching out to a known technical assistance center in the state that was familiar with what was happening there. And we also outreach usually 2 to 3 providers to survey them as well. This is separate from that national ACT team leadership survey, which I'll talk about a little bit later. We're trying to gather data across a lot of different areas: ACT availability, access to ACT, funding and reimbursement, policy regulations, fidelity monitoring, outcome data collection, workforce development. We wanted to hear from different stakeholders to see how much that they were coalescing around their responses so that we could come away with the most accurate snapshot possible. And sometimes we relied on some sources because they simply knew things probably more accurately and more reliably than another source. Data collection started in 2021. So after we're already a year well into the pandemic. And because this was such an exhaustive attempt to gather data, it took a lot of time to gather data across all the states. So we wrapped up literally earlier this year. We gathered information through an ACT screening tool to initially try to identify who had ACT or who had a model that they considered ACT light. Did they have specialized teams? And then we took that further to then do a deeper survey with a more exhaustive ACT survey. And then we follow up with what was called a semi-structured interview with our primary contact, which again was typically a state mental health authority. We would survey a couple providers as well. And then we compile this data into a large database for each of the states. We would try to discern where things seem to add up and make most sense given what the sources were saying. We compiled them into a state profile that kind of hit high points. We circulated that back over to the primary state mental health authority this spring to essentially get updates and correct any errors. What we didn't want to have is that states that participated in 2022 have data that now has changed. So we were making an effort to try to get the most accurate picture as we know it today. We had great participation. So off here to the right, you see the level of participation across these sources. And oftentimes we were pretty successful with getting participation, oftentimes because of the benefit of the warm networking we do with you all and across other networking sites. So now I'm going to speak to some of the results from this part of the project. How many ACT teams do we have? Let's take a look. And I actually didn't drop this number. If I were to add up how many teams are operating in the United States, it's likely around 1,100 in that ballpark. We had a few states, it was more challenging to pin down how many teams they had, in part because their state didn't have very clear expectations of ACT. They had another program that they would morph into being as ACT-like as possible. So as you can see, as the colors are going down deeper into the blues are states that have a lot of ACT. So I think New York has the most teams. And this is just, I also want to emphasize, we were looking at standard ACT teams here. It was the best we could versus trying to capture other adaptations and iterations of the model. We were most interested in what are we doing when it comes to just standard ACT across the United States. Then you see that other states have a healthy amount. There is this separate question about have we hit the right level of ACT given the population of our state? We have some analysis underway that's looking at this idea of like, are we reaching a decent capacity? You can see that states that tend to be a little more rural have, fewer metropolitan areas or cities go on this lower end of having ACT. So South Dakota, Montana have somewhere in the 4 to 8 teams, as well as at the time of the review, Kansas and Utah and New Mexico, Nevada. So there's a range here. The hashes that we see on California, Texas, and Wisconsin represents our mixed understanding right now of how many teams. California they are shifting this right now, but they have had full service partnerships, which some of them have been converted in some cities and counties to be as ACT-like as possible. But it was hard to pin down how many of the teams there were probably more ACT-like than the full service partnership programs. Texas was another state that was just challenging to get an accurate count of how many teams were there. We know they do have ACT teams, we just don't know how many. Wisconsin, which is the birthplace of ACT, keep in mind, and the original PACT model is still operating in Madison, Wisconsin, celebrating their 50th anniversary last year. They too don't have an explicit policy expectation and funding for ACT. They have something else that tries to get as close to possible as ACT, And some of those do decent with trying to implement to fidelity. But again, it's a mixed bag. And they have some grant funded teams there too right now. So it was hard to get a count there as well. And then you see with orange, there's a few states that don't have statewide act. They have typically federally funded grant teams right now through SAMHSA that gives them a count of some sort, but there's a question about the sustainability of those teams. Puerto Rico, I think, has been working on having a sustainability plan after their funding is coming to an end with their SAMHSA grant. So what's some of the history of these states around ACT implementation and plans around expansion? So as the table shows, and I'm going to just call out now, my table numbering and figures are going to be really wonky because I was pulling them from other reports that had a different order, and I was trying to erase them, and I didn't do a good job. So don't get confused by all that. But table 2 on this slide asks, how long has ACT been implemented in your state? So we had data across 46 states. Oh, back up 1 minute. I want to show this. 3 states don't have any ACT. So we were able to kind of discern that Wyoming, North Dakota, and Hawaii do not have ACT. They may have had history of attempting to implement ACT. Hawaii actually once did have a pretty solid attempt to have ACT, but then found it was difficult to sustain. So now they no longer have ACT. So we have 3 states who solidly don't have ACT right now. And then a handful of states that if it weren't for some federal grant funding, they too wouldn't have ACT right now. So looking at how long ACT has been implemented, as you can see in the table, which is pretty remarkable, that 57% have been operating ACT in their state for over 20 years. Then 30% have been 11 to 20 years. So 87% have been operating for 11 or more years in their state. Some are recent implementation efforts, which I think I captured here as well. South Carolina has a long history of having ACT in the state, but not as much as a statewide implementation effort, which they have underway right now. Idaho had a history of offering ACT. It disbanded for a while, and right now they're rejuvenating it all and now launching ACT once again across the state. So as you can see from the green states, these are states that the sources were saying we do have a plan for expansion. Expansion could mean a couple of things: increasing the number of teams, growing the size of the teams, and in some places it's ensuring that the number of slots they plan to have for the teams are truly being filled to capacity. That was the case for a couple of states. Then there was a few states that said we don't have plans to expand. And in some cases, it's because they went through an expansion recently and they kind of feel like they hit the number of teams they need. But then we had some states that we just weren't clear. We didn't know really what was happening and could really call it with some confidence. Or there were states that, again, didn't have ACT to begin with, which are the blue states here. So next question is, you can call yourself an ACT team, but you're really not an ACT team unless you demonstrate some level of fidelity to the model. So we asked about whether there is routine fidelity monitoring happening for these teams in the state. I want to note, this is a very generous interpretation of what constitutes fidelity, which I'm going to speak to on the next slide as well. So we have some states that currently don't have any fidelity monitoring happening. This is not including agencies that decide to do this for themselves for the sake of quality assurance purposes. So Illinois, Tennessee, Alabama, Arkansas, and California, as well as Rhode Island, were states that currently don't have fidelity monitoring. Then we had a few that we were again uncertain of. So for instance, there may have been one time that we're aware of that fidelity monitoring happened, but we weren't sure about whether the plan is for that to be routine moving forward, or it was kind of project-based. So, and then you can see there's a lot that are saying we do have statewide fidelity monitoring. So how is fidelity being assessed? 10 states are using the Dartmouth Assertive Community Treatment Scale, or DACS. Sometimes people refer to that now as the ACT Fidelity Scale that's in the SAMHSA toolkit. Of those 10 states, 70%, so 7, are using an external review team who is coming on site to conduct the review. That is a pretty standard protocol for fidelity scales, particularly ACT, but also for other fidelity scales too, for other evidence-based practices. So we were interested in what adaptations were being made about that process. 13 states are using the tool for measurement of ACT, or TMACT, which again, I'm self-disclosing, I'm a co-author of, along with Maria. And of those 13, 11 or 85% were again using an external review team who conducts the review on site with the team. Then we had 6 states that basically developed a version of their own measure. Most of the time it was mashing together pieces of the DACS and the TMACT. I think most commonly they were using the DACS, but maybe substituting in TMACT items, or sometimes they would make modifications to the scale. What we would see is modifications that seem to be more trying to reflect what they deemed as feasible for their state. So reducing, for instance, staffing levels, because they felt like it was tough to meet that level to rate a 5. So then they would make an adjustment to what it takes to make or to rate a 5. And then again, of those 6 states who have those modifications to their fidelity measure, 4 of them were again bringing an external review team on site to conduct the review. And then we have 5 states that we would call probably more of what they were doing is using a policy check tool. It wasn't fidelity. They had written code, regulations, and a way in which they broke that down to see if states or teams are following the details of the expectations of that policy. Who's conducting the fidelity reviews? So nearly half said a state mental health authority is part of that evaluation team or comprises the whole evaluation team. And then we have over half, 55%, had indicated that there's some technical assistant staff, like our group, the Institute for Best Practices, Maria's group, Case Western. There's many centers out there that have technical assistant staff who can go in and do these fidelity reviews. And then some had local mental health authorities that were more involved in the review process. And one had managed care organization staff as part of it. And then only 3 states utilized trained ACT providers, trained in how to do fidelity reviews, to be the ones reviewing the teams. Some, they would come in as the lead. They'd be contracted to come in as the lead and take over and write the whole report. Sometimes they are coming in as a co-evaluator, partnering with another entity like technical assistant staff, state mental health authorities. So we personally like that approach. I will share that the 3 places that use that model are Minnesota, Washington, and North Carolina. It's a nice way to help reify learning for providers when they get trained to be reviewers. So we're going to pivot to now talk a little bit more about how teams are being funded. And I see there is a reminder of using the Q&A if you have questions versus trying to sneak it into the chat box. And I'll answer Sarah's question real quick, asking, are we able to view the results of the National ACT study online? Not yet, Sarah. So we are working out right now all the plans around our deliverables. So we will be writing some up as manuscripts to get published in journals. But then the grand plan is for a lot of this is to live on our website as kind of like a clearinghouse so that you can go and grab, search by topics and look at information. And then hopefully the grander plan down the road would be finding a way to maintain some updates that come out of states as they're implementing ACT and making changes. Good question. Early on, trying to come up with a plan for all that. So moving on to how ACT is funded. We asked whether ACT is written into the Medicaid state plan amendment or SPA for each of the states. So as you can see here, most states that are implementing ACT, so I deleted out the states that are either very early on at the time. So at the time I didn't have information on Idaho, they didn't have ACT, or they only had grant funded teams. So I'm just showing you the other remaining states. And so many of them do have ACT written into their state, their Medicaid state plan amendment. And of those, 19 are using the Medicaid rehabilitation option, MRO, as the mechanism of payment or funding. And then 12 are using some type of Medicaid waiver. We also looked at the unit of reimbursement. We did gather information about how much reimbursement is. That's going to be analyzed and delivered in a different way down in the future. But I am going to show you how you are all being reimbursed. So when it says no, and I'm using the word bundled payment to mean the entirety of ACT, your staffing, the expectation of service delivery is paid for with one unit of reimbursement versus it's piecemealed through fee-for-service. Fee-for-service, you're billing a lot of different codes. A bundled rate is typically now going to be reimbursed using the code H0039, H0040. So the states in red had, at the time right now of our study that we know of, currently have no bundled payment that is specific to ACT. They may be relying on fee-for-services. They may have some other mechanism of how they're being funded, but it is not through anything that looks like a bundled case rate for ACT. Then we had some states we just could not pin down what it was. So for instance, Pennsylvania, you're in pink because it seems like the MCOs, the behavioral health MCOs there, do this in a very tailored way with the programs and can vary considerably. So we weren't confident in being able to say this seemed to be the majority of the teams. Then you have states that are being reimbursed with what is a 15-minute unit. So the good old like hit 8 minutes, round up to 15, that's what gets you paid with a certain rate. Most don't set a max on capacity of units. Some did. It varied considerably of what those 15-minute unit rates were as well. And I'm going to talk a little bit about what we see as kind of the pros and cons of some of these decisions. The blue states here are being paid with what would be a daily unit. So there is an encounter that happens or not. Sometimes the drawdown of the money can be based on just simply being enrolled on the team. Most often it involved that there was some encounter with the client that day. But if you saw them two times that day, 3 times that day, you only bill that one daily unit. Then a weekly unit is when you're bundling. This was more rare, as you can see with the green states, is that there was some expectation of practice, and then the payment would happen with getting a weekly rate paid back to the team. All of these can have some conditions on them. When you start moving out of the 15-minute unit, you can have conditions hanging on to the team of what does it take to get my payment for this client. Monthly unit. So the yellow states are paying out using a monthly unit. This is where it became more common that there's an expectation that you have to hit so many criteria to then draw down that monthly unit per person per month rate. Then the purple states are what we call a per diem. A per diem sounds like it's per day, but it really is a unit that gets customized given what the state wants to pay out for that unit. How many chunks of the money? I always think of it this way. States do cost analysis to figure out what do we believe it takes to fund an ACT team in this state or area. Then they decide the per person per month rate, and then they break it out to say, are we just going to pay that out in one lump sum, or do we break it out into smaller bits? So some states have used a per diem to break it out into chunks. So North Carolina is a state that uses a per diem where it takes what they believe is the monthly rate per person and they say, we're going to break this into 4 per diems that we will pay you across the month. And then finally, it was rare, but I think Connecticut, you're the only ones who have a situation with, it's almost like a quarterly payment that's happening. Part of it is because they're not relying on, you come back here, come back here, see how Connecticut is not a Medicaid state for their act. They have other sources of funding, so they've come up with other ways in which they're funding their programs and reimbursing them. So that's a lot of colors on the map, paying for a service that should be defined the same across states for the most part. And I think just to comment on some of this a bit more, which I'm going to give some information here, 15-minute units start getting to feel like fee for service, because what happens is the team starts chasing money all the time. Nickels and dimes is how I see it, to add up to what it takes to financially staff maintain this team. So it can be problematic to use 15-minute units, but that's a research question as well. So that's kind of a observation and hypothesis that would benefit from further study. The other ways can be better, but it depends on how complicated you make it. Some states made the rules of how you get paid pretty complicated. And sometimes we heard stories of where the teams would be like, we might as well just keep billing fee for service and do our best to do this model, because we'll probably be able to be financially solvent more so than trying to use the act rate. So there's a lot of interesting questions about how to do this the best way. Here's some additional observations when it comes to reimbursement. For 7 of the states, reimbursement varied based on the team size. So some states did toggle how much they paid out given the size of the team. 6 states varied payment based on who the MCO, it's not the states, within the state, individual MCOs or ASOs would pay different rates. So you could be a team serving 15 clients from this MCO, 20 clients from this MCO, and go on with that kind of breakout. And you may be getting different rates from all of those MCOs involved. That would be complicated to try to sort out as an agency in terms of planning, for instance. 2 states varied act rates based on the team location, so urban versus rural. 3 states varied rates based on where the service were provided. So they actually broke out and had a rate if you saw the client in the office and a rate if you saw them in the community. Another one had a designation of whether the rate was tied to seeing somebody who's residential versus non-residential. 3 states had established fidelity benchmarks that determine if the team is reimbursed with an act rate. One of those included an enhanced payment for higher fidelity teams. 8 states indicated they do not reimburse ACT for clients in supervised residential settings, or do so on a very limited basis with exceptions. So you have to seek an exception for this. I think it's pretty fascinating and ideal, but given the state of housing access, which I'm going to speak to near the end of this talk, I could see the strain on that too. Of the 7 states that are using monthly reimbursement units, 3 of them do not allow partial payments if all the criteria are not met. In other words, a team may provide some services to the client that month, but because they did not meet all the specific criteria for the monthly reimbursement, the team receives no payment for that client that month. So if I was in a room with 166 of you, I would see some of you go, because what's going to happen for teams that have that possible risk? And I'm looking at the chat box if anybody wants to chime in on that. What is the team likely going to do if they know if they may not get paid if they don't meet criteria, and the criteria is a little complicated? So I'll keep an eye on if anybody chimes in on that one before I give my, oh, there you go. Well, one person said lie. It does. Actually, you're not lying. It actually almost sets up teams to even entertain getting in the lane of doing something that feels fraudulent, and it's not good. Stop providing the service altogether. Somebody said they focus on people that they can bill for. That's the biggest problem. Think about this. ACT is designed to engage and serve people who variably see a need for wanting and needing services to begin with, but actually have a lot of problems when they're not getting any care or support. And doing really good assertive engagement, sometimes it's like you are lucky if you can catch them 2 times a month, or you are very careful about not overwhelming them because you're in this very delicate phase of engagement. ACT teams who are held to some really complicated way of getting reimbursed and then don't get anything if they don't hit it, go seek to serve people who are easy to engage and actually see, which then starts taking us away from the intended population for this whole model to begin with. Yeah, they'll see people they know is a sure thing to visit. Finally, 5 states reimburse teams based on the client enrollment on ACT or payment for an ACT slot. So there's almost like, we're going to negotiate how many people we expect you to serve. And we're essentially like giving you a retainer fee, just do your work. I think that's another interesting one to kind of look at what's the benefits of that. Like, if you have a decent reimbursement structure in terms of amount and the ease of teams getting paid, and then you build in the oversight, fidelity monitoring, support to make sure teams are doing what it is they're supposed to be doing, to me, instinctually, that's a good way to go. But it takes a lot of effort and structural resources to make that happen too. If a state has a lot of teams and don't have a lot of infrastructure support, that makes it more difficult to go that route. When's the last time the ACT rate was calculated? We tried to get these updates when we set the state profile. We got responses for about 2/3, so we may be missing some updates. But the best we know it is we have 9 states that it's been at least 5 years since they have recalculated their reimbursement rate for ACT. A lot's changed in the past 5 years. A lot's changed in terms of cost of living. A lot's changed in terms of staff retention on these teams, as we'll also speak to. When a team is heavily reliant on Medicaid reimbursement, you can't make big changes in how you're paying your staff and how you're providing support if your main source of funding isn't keeping up with updates of what it costs to do this service well. All right, I'm going to look at the question box and I'm pivoting to another part of the study, which is the benchmarking of ACT fidelity. Oh, okay, so let me answer this. Laura's asking, how many days of the month does a client have to be enrolled in ACT services for payment to happen? That will vary considerably based on how the state pays. So those that are at the weekly unit, daily unit, 15-minute unit don't usually have to worry about that question. It's the monthly unit reimbursement that the state may put some rules in around how you would get paid. So for instance, the only state that I recall that really broke this out with clear rules of like, you've been enrolled for this long, actually 2 states stand out that I think had some clear rules around this. And it was New York, which has a threshold that meets partial payment. And then I think in Louisiana was the other one that had a pretty clear breakout around like how many, the point of which you enrolled in the month yields this amount for the first month. And the other reimbursement structures tended, because of how they paid, not care about that question. It was only the monthly. All right, benching, ACT fidelity, and team and client attributes. There's a lot of data here, giving you a glimpse of some of it. So again, we reached out to every state that we knew that had been using the Team Act. Most of them had gotten training directly from us. Some of it was us being Maria and I in particular, and some of them got a lot of support kind of onboarding around Team Act reviews. We asked them to share with us the most recent fidelity review for each of the teams prior to the pandemic. We wanted pre-pandemic fidelity data. So just most recent, one per team. And we asked them to share the final report that documents the final ratings across items, but also typically document some specific things they saw too. And then also the team survey and a client Excel spreadsheet, which are tools that the teams fill out in advance of a review, hand over that information to the evaluation team. And that gets kind of worked into consideration around how they're viewing the team and making ratings. So that'll include things like staffing, what was is it a psychiatrist, nurse practitioner, both? What is the capacity of the team supposed to be? The client survey is de-identified. There's not PHI in it, but each row will be each client served and ask questions like, is the person in competitive employment? Do they live in a supervised residential facility where there's on-site med monitoring? Do they get long-acting injectable? Are they in competitive employment? Do they have a co-occurring substance use? Like there's a lot of information that gets shared through that spreadsheet. So we gather those from the areas using TMAC, create a big code book, an extensive code book that's pulling out, I think, 170 different coded variables. So the item ratings is one thing, including what are called sub-item ratings. So some ratings on the TMAC, you're going to give a no credit, partial credit, full credit. We're grabbing everything. And then we're grabbing some of those other data points I just shared with you that being somebody who does a lot of reviews, I know which ones tend to be more reliably reported versus ones that we can't trust easily. Like usually during the review, you find out something else and what they originally told you wasn't accurate. So we tried to get this on the data points that we were most confident in and pull all that into this data extraction book and then do the analysis with it. So a little bit about the teams, as you can see from these tables and figures, is that most of the data we gathered was from 2018, 2019 reviews. So they were pretty recent when we're talking about pre-pandemic data. And the team's length of operation on average was about 9 years. So these were teams that tended to be more established. They range from a team that had only been operating for a year to a team that had been operating for 29 years. And then it's away from me sometimes. All right, snapshot of the TMAC. For those of you not familiar, it's a measure that has 47 items. We're looking at 120 plus elements of ACT. We look at structural features of the team, such as staffing, who they're serving, level of care provided, types of services provided. But then we also dig into quality of care too. Are team members being used within their specialty area? What's the level of knowledge and skillfulness across different best practices? How person-centered does the team appear to be in their practice? And then the team act with all these 47 items, which are organized across these 3 subscales. You take all 47 items that are rated on 1 to 5 scale. 5 is high fidelity. 4 is good too. So 4 and 5s are good. 3 is a big bucket of okayness. 1 and 2 is low fidelity. We're not really following this feature of the model. The final TMAC rating is the average of all 47 item ratings. The operations and structure subscale is the biggest one with 12 items. It really is kind of the framing of the House of ACT. What is the team, daily team meeting, the client to staff ratio, extent of using the team approach. Core team is looking at the medical team and team leadership. So your team leader, psychiatric care provider, and nursing staff. Specialist team is getting into 3 specific specialists. We love more specialists, but these are the 3 that we focus on for the sake of this subscale, which is co-occurring disorder specialists, employment specialists, and peer specialists. Core practices, this is again pretty fundamental piece of the model. What's the average time you're spending with people? What's the average frequency of contact? Your use of assertive engagement strategies, contact with natural supports. Then there's the evidence-based practices subscale. So now we're getting at the skillfulness of delivering a range of best practices through the platform of ACT, doing evidence-based practices as it relates to support employment. or co-occurring disorder treatment for those with substance use, our work with families and natural supports. And then person-centered planning and practices is the smallest subscale with 4 items, but it really digs in to say, to what extent is the team being strength-oriented in their way of working with clients? Are they providing a range of services that reflects a range of life domains? Is there a good practices when it comes to developing and using person-centered plans? And then our efforts to really build up self-determination and independence, really trying to help people do more for themselves. So that's the overview of the TEAM Act, and let's look at some of the data. And reminder, if you're putting questions in the chat, I may miss them versus put them in the Q&A box. These are the average TEAM Act ratings across 11 states that we received the data from. Most states we had 100% representation. There were a few that were lower, but most were definitely 60% higher, most 100% representation. So we were seeing all their teams. So each column is a state. I'm rank ordering them lowest to highest. The bar that they're wrapping around is the average across all these teams. So their average was 3.68 fidelity rating for 222 teams across 11 states. So as you can see, there's pretty big range here. We're on the one end, 2.66, and on the high end, we're at a 4.13. We have planned analysis coming, and some we've kind of already started to summarize around the differences across these states, because there are noticeable differences. So not knowing who these states are, that's anonymous. Any guesses of what may differentiate the states who are on the higher end versus the ones on the lower end? And this is chat. Yeah, so Kelly's bringing up PACT versus MET, which is the Montana Act. So some states have broken out like specification of like this, we want to have ACT, but then we have a light model that we support. That wasn't the case for any of these states, for the most part, with one exception I'll speak to. Someone just saying staffing. No, it's kind of bigger things. Think bigger around that. Funding supported. So I would say the higher fidelity states tended to have 3 of the 4 tended to have more cost-based analysis to come up with a reimbursement rate that was tailored to the actual agencies. What happened here? Okay. So they were more customized reimbursement for those programs. Some on the lower end, I would deem lower reimbursement overall or not even a specific ACT rate. Higher end teams, higher fidelity teams, tended to be ones that had ongoing fidelity reviews. So these teams were accustomed to being reviewed, giving feedback. And then the lower fidelity teams, even though I have TEAM Act data, this could have been their only review they ever had. They've never gone through the cycle to keep getting feedback. Higher fidelity teams tended to be ones of states, sorry, I keep saying teams. States with higher fidelity tended to be ones who had some access of TA support. They had specific ACT training modules that staff had to go through as part of being on an ACT team, whereas lower fidelity teams at the time did not. So there were definitely differences. I think when we have a more like planful way of trying to capture all this, we're going to be putting that out there because it's a telling story of what we already kind of know, but it really kind of reifies it by looking at the data this way. Now, my clicker's so slow on me for some reason. There we go. This is a state that actually was not, they did not have an ACT reimbursement rate. They had no direction to do ACT. It was more like a needs assessment to see where is your current program at as it relates to this model, to kind of use that data to make an argument for where we really actually need more ACT support. take that state out of the data set for what I'm about to show you. So now I'm only going to show you data for states that actually were intentionally trying to implement ACT. So here's 10 US states across 206 teams. On average, the rating now is at 3.76. So not surprising, we remove that low fidelity state out, the average goes up to about 3.8. Now, for those of you familiar with the TEAM Act, some of this probably won't be surprising. And for those of you just, knowing how I describe these different subskills, it's not surprising. There's some fundamental pieces of this model that teams tend to do pretty well with, and it's the operations and structure and that core team leadership, medical team. So a lot of times these are pieces that are straightforward. They're explicit in a policy, like you need to have this level of staffing, these are the staffing of the team. This is the number of people you're serving. Here's the people we expect you to serve. So priority population. Then it kind of goes downhill as we need to rely on the team to do more when it comes to more rehabilitative and more evidence-based psychosocial practices. So specialist team, again, is our co-occurring disorder, employment specialist, peer specialist. And we're not just looking at, are they staffed with qualified people being used in the role? We're looking at the nature of the services they're providing and how are they working as a team, modeling, training, consulting with fellow team members. So now we're at 3.5. Remember, that's a big bucket of okayness. And the range here is concerning as you look at the minimum and maximum. Some teams hit a 5, which I think is remarkable. Some are scoring at a low 1. So they basically don't have specialist staff on the team if you're at a 1. Core practices, again, are pretty fundamental things like the level of care provided, use of assertive engagement strategy, penetration of using psychiatric rehabilitation services. We still are doing not great here at 3.6. Where it really kind of like goes down is when we're looking at that elevated evidence-based practices, the team's knowledge and skillfulness of supporting a range of practices, working with families and natural supports, the whole team supporting best practices with helping people get and keep jobs, going to school, addressing co-occurring disorders with substance use using some key fundamental pieces we know to reflect best practices. Then we have person-centered planning. Again, that's that strength-oriented, building up people to do more for themselves, doing really good person-centered planning. And this is our lowest, on average, scoring subscale. And we would say pieces that are in this one has this kind of trickle effect to other items too, that there's a lot of items that are interrelated. Now, I'm going to show you a comparison of teams that are lower fidelity and higher fidelity. And what we did is we did a simple quartile breakout. You look at the top 25% of the teams and treat them, so you rank order top 25%, treat them as one group. Lowest 25% are our lower fidelity teams, treat them as a comparison group. The breakout in our data set, and this is again with the 10 states, it's not that 11th state that was not directed to really be able to implement ACT. The breakout was 3.5 and lower on the TEAM Act is our low fidelity teams. Basically, a 4.0 or higher is our higher fidelity team. I will share as a developer and user of the TEAM Act, a 3.5 team is okay. They have a lot of promise to get better. So a 3.5 team is not quite the same as a 3.1 team. I can tell the difference of those teams. So, but this is how the data broke out for doing a quartile comparison. I think in the future, we're going to do a more kind of like stringent comparison based on fidelity ratings themselves. But I want to emphasize, I would know the difference if I walked into a team. If you had me visit 2 teams and said, which one is a 4.0 team, which one is a 3.5 team, I would know the differences. Like it's noticeable differences. These are not trying to parse out 4.0 compared to say 4.2, which gets harder. So as you can see, I'm looking at some just kind of core ACT service attributes. On average, so I show the mean to call our attention to that most of all, the staff to client ratio. So for every direct care staff, FTE, how many clients are being served? You've heard over the years that kind of reified 1 to 10, no more than 1 to 10. Policies get written 1 to 10. Lower fidelity teams tended to be 1 to 9, 1 to 8.6. Higher fidelity teams was a whole person lower, 1 to 7.6. That's actually a really big difference from the operation of the team, is when you can throttle down a whole nother person in terms of number of clients per direct care staff. This is a team approach. This is not about your individual caseload. This is about a ratio. We've been advocating for a while. We should be moving out of 1 to 10. 1 to 10 is hard to be at if you're truly trying to provide higher fidelity act. And this kind of reaffirmed our beliefs around that. On average with team approach, what percent of clients were seen by 3 or more staff in a given month? So that's an indicator of a team approach being used. As you can see, higher fidelity teams on average, it was 85% of the clients. And then for lower fidelity teams, it was 70%. So that's I'm not doing analysis because it's a huge descriptive study. And in the future, we'll do some planned analysis, just showing you the differences. Community contacts, higher fidelity teams on average were 93% of their contacts were in the community, whereas lower fidelity teams were 81%. Service intensity. So not to get myself tongue-tied, but think of it as for each client chart we're reviewing, we're calculating average minutes with them in a given week. When we're looking at 4 weeks, you rank order the clients and say who's in the middle. That median is what drives the score. So on average, lower fidelity teams are basically at 61 minutes per week as the average, whereas higher fidelity teams are at 79 minutes per week. And part of looking at data is looking at the distributions. It's looking at, are the standard deviation or spread roughly the same, or are they really different? What's the minimum and maximum in terms of the spread too? Service frequency. Again, 1.6 for lower fidelity teams was the average compared to 2.0 times per week. So they had face-to-face contacts, because we're only measuring face-to-face. On average, 2 face-to-face contacts per week for the higher fidelity team. And then contact with natural support is the percentage of clients served where the team had at least 1 contact with the natural support in that 4-week period. And you see the higher fidelity teams had a better percent there. And then a little bit more comparison here. Maybe if I can get my cooperation of my slides. Now I'm showing you indicators that could be framed as outcomes. We say that carefully because a big data set like this, it's exploratory. There's way better ways to create a research study design to get at the impact of ACT when it comes to client outcomes. So we are doing the best we can with the data that we had available. We have 3 measures. Really, it's 3 measures of outcomes here. One is service retention. What percentage of clients were retained on the team in a given year? The next one is looking at what we call hospital recidivism at the level of the caseload, because we didn't have this data for specific clients, but we could create a proxy index for the caseload recidivism into the hospital. And I'll speak more to that in a minute. And then what percent of clients are in competitive employment, but more so, what percent are in competitive employment and got the job with the help from the team? So as you can see with service retention, it doesn't seem significant, but it actually is a significant difference that on average, higher fidelity teams retain 93%, lower fidelity teams 87%. And part of it is that spread. If you look at the standard deviation, the high fidelity teams are tight at a 4.5 standard deviation, whereas lower fidelity teams have much wider distribution and go as low as the minimum was at 53% retention rate. Caseload, psychiatric hospitalization rate. Here's what we did. When you, a team's being evaluated, they're asked to list out the last 10 psychiatric hospital admissions, regardless if it's Mary going in 3 of those 10 times. We just want to know what's the last 10 psychiatric admissions when you're looking at the people served. We get the service, the date of the admission, and then we gather some other information for the sake of rating that item. What we did is we took the timing of the review and we counted the number of days does it take to back up to the 5th person that got admitted to the hospital, the date of that 5th admission. So how you look at this is for lower fidelity teams, on average, it took 48 days to get to that 5th admission, whereas for higher fidelity teams, it took 77 days to get back to whoever was that 5th admission. So there's more span of time happening to account for those hospitalizations for higher fidelity teams versus what's happening for lower fidelity teams. This is also going to be a significant finding, and we control for team size because that's a big thing you have to control for in the analysis. A lot of ways you can interpret this too. There's a lot of variables that I really want to look at if I did a better study around this with hospitalization. Employment. So as you can see, on average, for higher fidelity teams, 15% of the caseload is in competitive employment. Compared to lower fidelity teams is not that far behind with 11.5%. However, when you account for people who are in employment and got the job with the team's help, which is data that the team provides as part of that review, the gap gets significant. So now we have, for higher fidelity teams, 7% are unemployed and got the job with the team's help, compared to 2.7% for lower fidelity teams. When we do the analysis, we control for some things with the priority population. So that's one of the things around why it's important to look at not just who's employed, but did they get the job with the team's help? Is because for some teams who serve people who are deviating from the priority clinical population for ACT, you're serving people who may not have as many impairments and tend to be ones who just go get jobs on their own. So it's an important thing to kind of parse out in terms of how we're looking at this as an outcome reflecting the practice of the team. Last, pivoting over to the National ACT Team Leader Survey. This was the other big part of this project. In early 2023, so we collected data in January and February of 2023, circulated this across you all who have registered for these meetups, ACT Listserv, a lot of places we got this going, and we ended up getting in total 381 surveys back. Then we kind of whittled it down to reflect teams that were a little more confident about them having the experience of being ACT, really being a standard ACT team. So we chose to, again, keep the focus on those that call themselves more of a standard ACT team versus an ACT light or some specialized team. So we whittled down based on who's standard ACT. We further whittled down because some respondents would say that their team is serving 10 people. Some respondents said, my team is serving 200 people. Those who understand ACT understand that you're likely not an ACT team. You're making some really generous adaptations to what you're calling ACT. If you think you can, and they're not new teams either. So if you think that you can have that small of a caseload, we were conservative of how we drew these lines because I have concerns about a team serving 15 clients, but we closed it up to say you had to be at least 15 clients to 150. Then we also looked at the total FTE staffing and brought it down. If a team said, I have 50 FTE staffing, something is being reported on that's not ACT. So again, we had some conservative lines drawn to try to get this a reflection of what is probably an ACT team, but we don't know for sure. So all in all, and then we cut it down to having respondents that had some experience of working with folks with serious mental illness. So when all said is done, we have 306 respondents part of this analysis. We developed a big survey, cut across a lot of areas, had 62 questions in total. So here's some of the findings about the ACT teams. Caseload sizes. So as you can see, it varied. Most teams, 39%, would call them, they were a medium-sized team. Then you have 32% who were small teams. So we define small as serving 30 clients to 59 clients. Then we had 20% that were a large team. And also then we had these fringe ones that 120 to 150 is very large. And if we did a fidelity review, I think there's pieces of the model structurally that probably are off. I'm equally concerned about teams that are at that lower level of closer to the 15, 20. It's financially not viable to do a team-based approach in the way the ACT is designed versus pulling staff from different programs to kind of retrofit in some of their time to serve the ACT clients. So again, we were conservative about how we were trying to exclude and include teams. Length of time operating. So similar to what I showed you earlier with the Team ACT data, most teams, over 60%, are operating for at least 10 years, but then we caught a few that were operating that are pretty newly implemented. What's the size of their catchment area? So this is them, we're not analyzing this, and it's an anonymous survey that they could put their name in the bucket to be part of a raffle to get $50, but no name is tied to any of this, or even a city. So we just knew state. So we had most, 32%, said that they are serving a population catchment area that has 500,000 or more people in it. Then we had 25% said it was between 200,000 to near 500,000. Then you see going downward, the smallest catchment area was under 50,000 and 12% said they were serving that area. So clearly a more rural area that they're operating in at that point. Or not, or it could be a small city that stayed contained, which is going to be the point of my next slide, which may cross your eyes trying to make sense of it. So I'm going to show you and walk you through this and keep thinking of better ways to present this. I'm showing you data. So I'm going to get I think I can do this. No, that's it up. It's going to try to highlight a little bit. So this is talking about the teams operating in an area that has 50,000 or fewer in the population. That was 33 teams in our data set said that was true for them. We further break out, are these teams that were very small, medium. So rural teams, that these are likely rural teams, you expect them to likely be more small teams, which was the case. So some were very small. They're in that kind of, if you're close to 30, it's one thing. If you're close to 15, there's questions. Then within each of those teams, we're further breaking down to say, this is how they were asked the question. When you think about the furthest a client lives in terms of drive time from the ACT office to getting to see that client, so one way, how far do you have to go to get to the client who lives the farthest from the team office? So they first answer that question of how far are you driving? Is it within 30 minutes, within 60 minutes? Or sorry, the options are within 30, within 45 minutes, within 60 minutes, within 90 minutes, or 90 or more minutes. And so they're picking that first. And then there's a follow-up question that says, how many clients do you serve that tend to live that far away from the office? Then they have some choices again, 1 client, 2 to 4, 5 to 10, 10 to 20, 20 plus. Now in the cells, you're seeing how many teams, how many, say, very small teams reported out they had to drive more than 90 minutes to see the furthest client. Well, it's only one team, and they said it's only one client. Then we have another team that said the furthest I go is within 90 minutes. So we're getting close to 90 minutes, not 60. And one team said that's true for 5 to 10 of my clients. Now, keep in mind, this is a very small team. 5 to 10 clients now could be a third of your caseload. You're going that far away. That's how you read this. It's busy. And actually, I tried to... Oh, there you go. So I circled the ones that stand out to me as being of concern. Part of it has to do with the number of clients and also the distance you're going, but also taking into account the size of the team. The problem with this is beyond the catchment population size, it's about spread. And spread means you are adding a lot of indirect time to your work. And then it's a matter of math. The more indirect time you add to your work, the less direct time you have to deliver services. The other concern about catchment area spread is that particularly those clients that are living further away, they are very likely not getting ACT. They're getting somebody on your ACT team who lives closest to them that often can see them. They can't get the intensity of services. There's a lot of pieces that fall away at that point. So this is, again, we broke this out and we're looking at it for each of the catchment area population sizes, but it's a kind of a point to be considering when we're thinking about ACT implementation and where to implement it. Pay attention to time. I'm gonna hit some of these quicker. Is the team adequately funded? Are you surprised to see that there's some folks who are feeling like their team is not adequately funded? So we're about 37% said no, disagree, not. Some weren't sure, but some actually felt like they were adequately funded. And keep in mind, for many states, this also happened. The survey was given before the state did a recent update to the reimbursement rates, so we're not sure the implications of what changes that would have had for that. What positions are difficult for you to hire and retain qualified staff in? So we hear this a lot, that it's the licensed clinical therapists and social workers are particularly challenging, as well as our co-occurring substance use specialists and registered nurses are the three bigger ones. Then I may have shown you this before. We asked, do you believe you have access to these different aspects of running a team that really can enhance job satisfaction for the staff? And then there's a follow-up question. If they said yes, they had access, there's a follow-up question asking, do you believe that it's of sufficient quality and quantity? So a lot of teams are having access to agency smartphones. There's mileage reimbursement, sometimes not sufficient amount. Questions about use of company cars, having flex time, license supervision. What I'm going to pull us down to is the very last one. Opportunities for salary increase. This is kind of I should have put the data label in, but it's about 58% said yes, we have access to opportunities for salary increases. Is it sufficient quality? No. See how that drops down? Not sufficient quality. So it's not a meaningful increase. Length of stay on ACT. So we're pivoting to look a little bit more at the clients served by these teams. You know, for some teams, they may operate from kind of an old way of thinking of like ACT as long-term service. If you're serving people who need it, they're going to be on the team forever. We know a lot of people don't need ACT forever. We're promoting graduation. We want to help people get off the teams. So we asked the question, what percent of your caseload are clients that have been on the team for 5 or more years? We're only asking this of teams or analyzing it for teams who've been operating for at least 5 years. In this case, the breakout I had to use was 6+ years. 5 or more years. So I hate that this is a percent of a percent, but let me talk you through. 7% of the respondents said that 81 to 100% of their caseload have been on the team for 5 or more years. So nearly everyone has been. Then you go down and you see that 13% of the teams who responded said it was much fewer. It was 1 to 20. Now that's a quick turning over in my view. If you have only up to 20% of the clients served, you've been operating for at least 6 years, and only 20% have been there for 5 or more years. We don't know what represents probably the most ideal situation if you're a good team serving the right folks. This gives us some insights about how to ask this and look further. The next one, though, is asking about of teams operating for a longer period of time, what percent of the caseload have been on the team for 15 or more years? And thankfully, most said, so here you see 6% said no one's been on the team that long. 63% said it's up to 20%. 1 to 20% have been on the team for 15 years. So it's pretty rare to see teams that have a large percent on that long. But again, look at a few respondents that really did. Their clients are not moving off the team. We asked about what has changed in terms of who their clients are, who's being referred to receive ACT services. So this is getting it from the perspective of teams who have been operating for at least 3 years, so they have that kind of ability to look back and compare. So 44% said that the folks being referred to them have increased severity of physical health impairments. 53% said the severity of the psychiatric impairments are increasing. It's more pronounced. 77% said there's increased severity of housing insecurity and or homelessness. 71% increased severity of substance use challenges. In a comment box, the most frequently cited comment, I would say, people adding something, is that people coming with more of violent history, more concern about risk, was another one that some people would add. I would guess that these are familiar to a lot of you and what we've been seeing. And it's going to beg a question I'll have at the end if I can get to it, because my case is not the greatest right now. Do you have access to affordable housing? Gosh, you're a team that's supposed to be serving people in integrated settings in the community, not in group homes, not in hospitals. You're trying to help them create and keep homes. Where do you find those homes? So we asked, what is the availability of safe and affordable housing units in your area? 76% said very low supply. Another near 20% said somewhat low supply. So these kind of are like duh questions, but when you put it to numbers, it reaffirms things that you all have been sharing with us and we've been seeing as well. Then we asked, what percentage of ACT clients who are unhoused or unsafe housing? So where they're at is not very safe housing to begin with. So the column here is the percent of clients on the caseload that are in unsafe housing. The higher level is saying 31% or higher in this situation. 8% of the respondents endorse that. Whereas it trickles down. 32% of the respondents said that it's very few of their clients are in unsafe housing. But it varies. We have a lot of different responses here. What percent of the clients are living in supervised residential settings? Remember earlier, there's a few states that won't allow it and pay you for ACT, which is going to drive some of this 23%. But we have 44% who said 1 to 10% of the caseload is in some type of supervised setting. My concern are the teams that are on this higher level. When you have a third of your caseload in supervised setting, it may be that you just are really struggling to find affordable housing and you're in a predicament right now. It may be that you've been allowed to do this and there hasn't been a concerted effort to help people get out of these supervised settings. It's an expensive way to pay for ACT if it's just overlaid on supervised settings. So it's another thing to further explore the why behind it. Gosh, we may not have open mic. I can stay a little late if we do a little open mic, but I also know that my colleagues here also need to get off. But quick summaries, wide variability going on in terms of how many teams ACT, how many teams states have. Some questions about, have you fit the right level of capacity? 3 states have no ACT. Another 3 basically have no ACT if you wasn't for the federal grant funding of doing some sponsorship of teams right now. Fidelity is all over the place. You know, most teams are using the DAX or Team ACT. It varies in terms of expectation of external reviewers coming on. Some are creating their own tools. There's debate about, like, you know, how useful is that to just keep cobbling together your own tool? It makes it difficult to make comparisons is one thing. There's wide variability in how teams are being reimbursed. This is one model with a pretty clear definition, yet we are all over the place on how we're paying these teams. There probably is some models out there that work better, and it's something for us to be looking at. There is We have 8 states who haven't updated the reimbursement rates for 5 or more years now. And we have to look at that if we care about staff retention in particular. On average, teams that are in areas trying to implement ACT with intention, the average is 3.8, which is not bad as an average. And some states were on average doing quite well with this. It's range, and as I spoke to, we think there's some things that tells a difference between those high fidelity states and the low fidelity states. There are observable differences in performance and potentially outcomes, as we would predict and what research has shown in the past with being lower fidelity and higher fidelity. We have a depleted workforce. See my last bullet? Most states said they're going to expand. How do you expand if we don't even have staffing for the current team? We have to treat this topic with the urgency it needs because it's a big one. Who is being referred to ACT as shifting? And we have to look at what are the implications of that for the team, and where is it that the system is failing to meet the needs of all those individuals. There's a question about, do we have good crisis stabilization units, respite beds? Do we have enough hospital beds for people to go in the hospital when they need a longer stay versus constantly being cycled in and out? We have a crisis in housing. And so we need to look at ways to keep being creative on trying to invest in affordable, safe housing options for folks as well. I'm going to stop here. You can see the broader recommendations. More will be coming out, and I want to get to the Q&A box. And I'm so sorry I left no time at all for just open mic. Does the dual diagnosis staff person replace the SUD staff? Yes, it's all reported. It's all treated synonymously in terms of the language here. What few pieces of the big picture advice would you give to states or funders about how to move their systems to high fidelity teams? I'm probably landing on the slide that best answers that question. So I'm going to say that we're answering it by looking at this, but we're definitely going to be coming out more with this. So, is there any correlation via data or anecdotally between the percentage of clients who are stably housed and fidelity regarding contacts and time spent? Wondering if programs that have a high number of people experiencing homelessness have lower fidelity in those areas given funding challenges related to outreach, or if there is no correlation. For example, if more people are living at home with families and have more family support, do they have different outcomes? That's a great question. And one that we may have somewhat limited data on. We have one data point in the fidelity that could give us some indication of maybe they're living with family, but it's not, it would be extrapolating a little bit. I do think that the question around, does amount of time correlate with helping people succeed with being more stably housed? The thing that we're missing that I think needs to be adjusted for in the future with fidelity reviews is we carried forward the practice of looking at means and medians for minutes and frequency of contact. That is a good index, but what I actually care about equally, maybe even more, is I want to know how high is high for your team. So it's one thing to be on average 2 times a week for a client, but if 2 times a week is pretty much what you're doing for everybody versus realizing you're serving some people who need daily contact from your team, we're missing the upper quartile of data that I actually think is a better representation of what the team is doing, because they have some folks that barely can stand being seen once a week, poorly engaged, doing pretty well, getting ready for graduation. So I think there's a richer story to tell about ACT practice if we looked at that frequency and intensity data a little bit differently. Do you have a particular metric for defining safe housing? You're putting me on the spot. So in the client survey, we do have definitions for those questions. And I'm trying to think if we go into much detail with it. So that one I may not be able to answer live. And if you want to get out of your anonymous status and just email me. I'll do my best to see if I can find that. All right. It is 4:30, but my goodness. I didn't give much time for open mic. Here's what I want to leave you all with, and I can stay if we can stay for a couple minutes. There's an evaluation that has been dropped in. Love to get your feedback. Maria and I are committed to supporting you all. One thing to note, we launched this meetings before the MHTTC through Northwest sponsored it, because we just knew there was a need to support you all when the pandemic was just throwing everybody on their head and trying to help support you all work through this. And then everybody valued just trying to focus and get together and learn and all this stuff. So we want to continue this, and we're going to commit to you for a year. And then while that year's going, we're going to continue to look for other sources of funding that fit us and what we're looking for. But Maria and I, our shops are just going to sponsor this on our own and do it. So more to come about a new registration link, a new way of meeting, whether it's Zoom or not, but we're going to stay with you and figure out how to make this work with you all. Oh, I like all the hearts. And yeah, so thanks. The person said they're going to follow up with me about all those housing questions. Yeah, so much information. Can you believe that what I shared with you is like 20% of the data set we have? We have so much information. So a big task is figuring out the best ways to share it with you all the stakeholders that are going to benefit from it, and get it out in a timely manner. So there's a lot more to come. You all just get to be the first ones to get the tour of it all, the most we could in 1 hour and a half, apparently. A lot of friendly faces out there. So thanks, Leah. Rick, Kelly's out there. Lots of folks are out there. So thank you all. Till you hear from us, we will be getting back with you all with next steps.